So I'll start.
Yeah, please start. We are live.
Yeah, I welcome all of you to this masterclass on hysteroscopy, the usage of hysteroscopy in infertility. And as we know, Dr. Jay is a very accomplished endoscopic surgeon. So we will be only talking which is relevant to fertility practice today in hysteroscopy. So in between last week, couple of days, we were unable to take the master classes because of Dr. Jay being in Bangalore. And we had a fantastic surgical work, which we did in like 24 hours. So today, again, we are going to start the sessions regularly. So over to you, sir.
Yeah. So actually, this is the most important topic as far as fertility practice is concerned. This encompasses fertility practice right from your ovulation inductions till IUI, till IVF, till failed IVF, till recurrent pregnancy loss, every damn thing, right? Now, one thing we know that 3D ultrasound is something which is very good. It helps you identify anatomical defects. It helps you identify the contour of the uterine cavity, and it helps you identify the volume of the uterine cavity, apart from the vascularity. So that is something which is very good as far as 3D ultrasound is concerned. So people often think that I have a great 3D ultrasound and I'm doing my 3D ultrasound so well. So then why should I even think of doing a diagnostic hysteroscopy? Okay. Actually, diagnostic hysteroscopy is then boiling down to the microscopic level of what is happening inside the uterus. All right. And I will just brush up the entire aspect of diagnostic hysteroscopy, which every fertility practitioner should be aware of. Okay. If you think you want to practice fertility, then apart from your 3D sonography, 3D ultrasound, your diagnostic hysteroscopy is an absolute must-have. Okay. I would just go through the basic requirements, what you need in order to establish this thing. So first thing, let me tell you, though we consistently talk and though I'm going to show you office hysteroscopy, kindly learn to do office hysteroscopy in an OT. Okay. That is the first thing. All right. Office hysteroscopy is something which does not require any form of anesthesia. In fact, that is the reason why it has been documented as office hysteroscopy. And then when you do an office hysteroscopy, you are supposed to do it on an examination couch. But we prefer to do it inside the operation theater just in case we require anything. Okay, that just in case is very important. All right. The setup which you need to do, I'll just switch to my screen sharing. Shilpa madam, stay on unmute, please. And so I will switch to the screen sharing where I actually created this video today. See, this is your diagnostic sheath, okay, which I have held in my hand. This is the standard diagnostic sheath, and this is the standard 2.9 millimeter. What is 2.9? The diameter of the tip there is 2.9 millimeters. Okay, this is your standard rigid hysteroscope. So when you put a diagnostic sheath above a 2.9, it becomes actually 4 millimeter. Okay, this diagnostic sheath is around 1.1 millimeter larger in diameter than your rigid endoscope. So when you assemble your diagnostic hysteroscopy set, okay, you need to ensure that these two are in the same line. Okay, there is a locking mechanism inside. This is the standard for almost every hysteroscope on earth for the diagnostic sheath. You just screw it in and you lock it. Once you lock it, you have an inflow channel from where your distension medium is going to flow inside, as you can see. And it is important to understand that at the tip, see, I'll just show you the tip. At the tip, see, there is that gap between the endoscope and the sheath. This allows for the fluid to come inside and distend your uterine cavity. Okay. Now, once we understand this entire thing, that is the light source, and that is your telescope which gets connected to the camera head, okay, of whatever machine which you are using. All right. But it's also important to understand that we will not be able to demonstrate the vagina directly. So let's assume for the time being that my left hand is the vaginal orifice. Always ensure that the snout is posting towards the posterior vaginal wall. When you enter in the vagina, it should post towards the posterior vaginal wall. All right. That is important. So that whatever water whatever normal saline is coming in from the channel, it gets dispersed in the posterior vagina. Otherwise, what will happen? It will go over your scope and sometimes there will be a bubbling effect. And if you are a newcomer, not very experienced, you may make some mistake in identification and visualization. So always keep it on the posterior wall. Then once you enter inside, once the vagina distends, once you have closed the labia majora can be approximated so that the vagina distends. And once the vagina distends, it becomes easy. You see, it is something like this. Okay. You can beautifully identify the vaginal walls. You can identify the cervix. Okay. This is a live procedure actually, which we did today. So the whole thing, I just made a video from the hospitals to show it to each and every one of you. You can see that is the external orifice. So you've assessed the posterior fornix. You have assessed the external orifice. You can see the cervical glands inside. Okay. Assessment of cervical glands is important. Sometimes you may identify cervical polyps. Cervical polyps are important to identify and cut. Okay. Because they may cause some bleeding through your cervical canal and the patient may get worried as to what is this happening. All right. Now, this is a particular patient who was referred to us for an office hysteroscopy because it was told to have cervical stenosis. Okay. Now, remember, there is nothing called as cervical stenosis, to be very honest with you. Okay. Then the patient will not menstruate. Of course, you can have a tight cervix, but you can see that we are distending right through the center. We have identified that, okay, we can see the orifice now. Once we see the orifice, okay, the patient is absolutely not feeling any pain because what happens is you are in the cervix and it is getting nicely distended. That's the orifice. Can you see that? Everybody can identify that. That is the orifice. See, you can see you need to just rotate it. Okay, your hysteroscope needs to be rotated from 9 o'clock to 3 o'clock. See that? I'm going from 9 o'clock and going to 3 o'clock. Okay. I'll just come out a little. Again, I'll go inside. Just rotate it 2 or 3 times very, very gently. The minute you are able to rotate it very, very gently at the level of the os, patient will feel a small little ouch. Okay. Because that particular part of the orifice seems to be blocked. Okay. So patient will feel that little ouch type sensation. Okay. It will not make her scream. See that? Those fibers you can see now breaking away and giving way. I actually wanted to show this. In this event, you can slightly increase your distension pressure. So I have made the distension pressure currently at 100 millimeters of mercury. When I entered, it was at 80. Okay. And the cavity opens. See that? You don't really need any dilatation. You just need nothing. Okay. This then goes beautifully inside. You can assess the internal os. Very nice internal os. I can see the cavity. It's an excellent, wide, roomy cavity. Okay. Always locate the ostia. There is a small polyp there on the fundal wall. Okay. Anterior, on the anterior wall, you can see that there is one ostia which is visible on this side, the other ostia on the other side. It is a beautiful, roomy cavity. One need not do anything. From the internal os, when you have a picture like this, you should be happy. Simultaneously, you should also end up assessing the walls. Can you see? You assess the vascularity of the walls. There is good vascularity coming in. Okay, it's a beautiful picture inside. This is a good uterine cavity. These type of patients would normally develop an excellent endometrium. There is no need to traumatize this cavity in any manner. Right from the internal os, with gentle movements, you will be able to identify everything. Okay, and then you can safely come out and tell the patient that everything is fine. They can actually go back home. And once they are home, probably in the next cycle, they can come back to you. And when they come back to you in the next cycle, you can probably start your treatment. All right. Now, this is one simple aspect of something which all of us should do. Okay. I will also go on to some finer points of this entire thing. There could be occasions and instances where in previous failed IVF situations, you have some amount of granulomatous changes, which you see inside the cavity. I think Dr. Shilpa probably has a video because we had a cavity like that in Bangalore this time when we did. These are patients who are having some form of chronic endometritis, which is typically visible as micropolyps. Dr. Shilpa, do we have that video? If we can, you can play that video. Yeah. So that type of micropolyps are typically an indication of some form of infection, which is going on inside. Usually, it is these type of patients, whenever we have these small infections inside, they should be treated with antibiotics. prior to giving them any other form of, embryo transfer or endometrial preparation therapy. That is something which is very common. It is routinely missed out on your 3D ultrasound, but it is something which is picked up on your office hysteroscopy. Okay, that is something which is very, very common. The second thing which is very common is something like this, a tight internal os, if I may just call it that way. All right. You also saw a polyp inside. So this polyp, in fact, the next video was that, but I did not play it because, we did a polypectomy as an office polypectomy for her using scissors. Now, you have seen me many times using electrosurgery as well as using scissors, right? I am somebody who is comfortable doing both. I am somebody who is comfortable using both. All right. But it does not really mean that everybody should use scissors only, or everybody should use a bipolar resectoscope only. Correct? It is completely your choice. Remember, your injury to the basal layer of the endometrium depends on how well you use the instrument. Okay? It doesn't depend on what instrument you use. Of course, it depends on your technique, but it depends on how well you apply that technique. Okay? That is something which is very, very important to understand. Shilpa madam, can you play that video of the chronic endometritis picture?
We'll do that.
Yeah. So if we see, this is a small clip which we had shot in Bangalore. As a part of one surgery, we had seen the endometrium. I hope the picture is clear.
This was for stem cells, which we did.
Yeah, this was for stem cells. It's the video is a little whitish, madam. Yeah, one can see those micro polyps there at that angle, right? It is this micro polyps which are very, very typical of chronic endometritis. So if in case you end up seeing them, okay, it is important that these patients do get treated for a course of antibiotics prior to you planning your embryo transfer on all of these patients. All right. We will also be taking a very good session on Asherman's. So I'm not going to be discussing anything about thin endometrium at this point in time, because it is a proper session which we are planning to do. All right. Simultaneously, I also want to tell people that whenever we are doing a diagnostic hysteroscopy, okay, you must almost always take consent for an operative procedure as well simultaneously. See, many a times when you put your diagnostic scope inside, you may feel that one wall is pouting in, the other wall is not pouting in, query T-shaped uterus. You may diagnose and locate many things. You may find a small polyp. In that particular situation, there is no point running out and taking further signatures of the patient and doing all those things. Simplest options are really simple options. Take consent for operative scopies simultaneously when you do your diagnostics. And when you take a simultaneous consent, you will end up treating most of the procedures which you see on a diagnostic hysteroscopy. Right? Now, one more important thing. These days, a lot of new devices are going to get flooded and have already started flooding the Indian market as far as disposable single-use office hysteroscopes are concerned, which have a beautiful, nice, small 6.6-inch LED screen at the outside, and the basic premise which they tell people is that, okay, when you have this particular hysteroscope, the thing is, honestly, it is just diagnostic, that particular thing. You can't really do any procedure which you feel like doing with that. Okay. All you can do is you can see the cavity and you can come out. And the visualization is definitely not Ultra HD. See, most of the screens which we currently have, okay, and most of the rigid 2.9 endoscopes which you see, the rigid 2.9 endoscope is going to cost you approximately, all right, approximately 2.5 to 3 lakhs. All right. Your rest of the hysteroscopy set with your instruments, diagnostic sheath, operative sheath, and everything will cost you another 2 lakhs. This is when I'm talking of buying the best of the best. All right. So that's around 4 to 5 lakhs. The routine Hystromat, I'm not talking of the Medex pressure bags. I want to come to that point. We don't use it. We don't use a Medex pressure bag in our hospital. It has been a Hystromat since the last 7 years. Okay. So what typically happens is a histomat, an Indian made histomat, is typically going to only test the pressure of the water going through the channel. Understanding? It is good enough. It doesn't really measure the intrauterine pressure, but it costs you around 3.5, 3.5, sometimes 4 lakh rupees. So on an average, in around 10 lakh rupees, you can have an excellent operative hysteroscopy set, okay, which includes your resectoscopes. All right. Maximum what you might end up spending is around 12 lakh rupees. Okay, 2 lakh rupees up and down. But that is going to last you for maybe 5,000 cases. Okay, so if you see the total utility, then the utility of investing in a good hysteroscopy set is way more than investing in these disposable instruments. So just be aware of that, because it is going to be flooding the Indian market from the next financial year onwards. All right. Now, before I conclude, there are certain small things which I want to tell people. See, many a times, we have done a diagnostic hysteroscopy in a patient who has just finished her menses. Okay. In that situation, what will happen is there is going to be some blood clot lying here or there. Okay. This particular blood clot in a diagnostic hysteroscope is going to come and obscure your vision. Very simple, right? See, one of the best things which you can do in a situation like this is you can put your pressure just below the clot. Okay. It will automatically dislodge it. Okay. Even before your camera touches it. And by mistake, if it has touched your camera, then just swipe your camera along one of the lateral walls. The clot normally gets dislodged. All right. So that is one common thing which people often ask about a diagnostic hysteroscopy in fertility. A very common question which people ask is, can I do a diagnostic hysteroscopy and an embryo transfer in the same cycle? Okay. Now that is something which is highly not recommended, because once you are doing a diagnostic hysteroscopy, let's say on the 5th or the 7th day, that is when your functional endometrium is about to begin its own development, right? The endometrium is divided into 3 things: basalis, compact endometrium, and functional endometrium. Your functional endometrium starts developing once your lead follicle becomes approximately 11 to 12 millimeters. So when you do a hysteroscopy at that point in time, you are highly prone to causing some amount of injury to the functional endometrium. Okay. So should you be wanting to do something like that, try and avoid. So now the question which people will ask is, Acha, you are saying to try and avoid, but what if there is a patient who has come from abroad and there is a small polyp which you have seen, and that polyp has to be removed? What will you do in that situation? So I have myself posted many of these videos where I have removed these polyps in the same cycle and an embryo transfer has happened. People do become pregnant. I don't deny that. But if you have the liberty of time which is available, okay, then kindly do it one cycle prior. That is something which is important, unless there is an emergency situation. One of the best ways to do a diagnostic hysteroscopy is something which I think it is a good way. So I follow it. Dr. Jatin Shah follows it. We are both very good friends. The day you are doing your ovum pickup, okay, and you want to assess something, in that ovum pickup, you can put a hysteroscope and see. Okay, so the second thing which people will ask in this is, worry, but endometrium is, fluffy, and you can't really identify so many things on the day of the ovum pickup and all these things. The day you start doing a hysteroscopy with your ovum pickup, you will realize what I'm saying is true. It's very easy. You will identify the polyp as a polyp, fibroid as a fibroid. You will identify everything, and you will be able to treat the pathology in a single anesthesia. Should you think you need to do that, you will easily identify septums. You will be easily able to cut the septums on the same day. So don't worry about it. Okay, that is one thing. And finally, before we conclude and I ask Shilpa madam to ask questions, people often ask, do we need to give any pre-treatment, okay, prior to doing any of these hysteroscopies? See, we don't give. Okay, we try to do the hysteroscopies honestly at any time of the menstrual cycle when the patient wants to do it, because most of the features are going to be the same. It doesn't really alter the outcomes. In fact, it doesn't alter the outcomes at all in thin endometrium, because the endometrium is thin any which ways. Okay, but when you are looking at a diagnostic procedure and you are very fussy that you want to do something about it, then one of the things which you can do is give a luprite depot around in the previous cycle. It will really cause endometrial atrophy very beautifully, and you will be able to identify, just in case you want to identify the walls, and you will have a crystal clear picture. But apart from that, we don't recommend any pre-treatment for doing a diagnostic hysteroscopy. Okay. So with this, I conclude this very basic session and we will move on to questions from Shilpa madam.
So when is that, what is the indication in your setup or in your practice to do a hysteroscopy in infertility patients?
See, most of the times what happens with us at least is that we end up getting patients who have at least failed 1 or 2 IVF cycles outside. Okay, we will very rarely get a patient who is doing a primary IVF cycle with us. Okay, so in that particular situation, more than 50% of the time, we would want to put an office hysteroscope and at least rule out if everything is fine or not. And you will be surprised, a lot of these patients come back to you with chronic endometritis, unexplained infertility, right? Unexplained infertility, 3 IVF cycles failed, excellent blastocyst embryos. Patient is wondering why something like this happened. You just give them a simple course of doxycycline. Okay, simple doxycycline with clindamycin to the patient, and patient will be superb. Next cycle, the endometrium is brilliant. The cycle after that, you can do an embryo transfer. Okay, so one of the indications is failed IVF in my practice. The other indication for diagnostic hysteroscopy is not there. We normally do it for any pathologies, polyps, submucous fibroids, and all these things.
So what about in cases where they don't develop triple line or thin endometrium?
So yes, see, in thin endometrium, one thing is very, very important. Any patient with thin endometrium, put an office hysteroscope. In more than 30% of the occasions, you will find some intrauterine adhesions which have been not picked up on a 3D ultrasound. Flimsy adhesions not picked up. You know, adhesions on one lateral wall which is causing a distorted endometrium has not been picked up. Okay, many times you will find this. Many times in patients of thin endometrium, you will find this chronic endometritis picture. Just treat that chronic endometritis 21 days. Okay, 2 cycles after that, the patient's endometrial flow and the development will become much better. Okay.
Okay, so polyps we see very often while stimulating during IVF stimulations or even IUI stimulations. So what size of polyps you remove and what?
See, we had a huge debate about this on the Bangalore group, right? And till a point that there was somebody who was mentioning that he or she would not remove polyps which are 1 centimeters or lesser in size, because some paper from Kazakhstan reported this with 35 patients or something like that, right? Honestly, I did not go through that paper as well because it is rubbish. It is so difficult to counsel a patient who has a polyp, okay, and tell the patient that don't worry, okay, let the polyp be there and you will still become pregnant and nothing will happen. See, this is a world which you are living in where information is available abundantly. Okay, if polyp is available, if you don't recommend to do a polypectomy, their friend will recommend them to do a polypectomy. Understanding? So you must give the option. Let the patient choose out of it, right? If you think that there is a polyp of 1 centimeter, knock it out. If you think that there is a polyp which is very small, 3 millimeter, 4 millimeter, that's okay. That could be an endometrial aberration also. But if the polyp is 5 centimeter, there is a pedicle, there is a vascular stalk, even if it is in the center. A lot of times people say, "Arey, my polyp is right in the stripe, yeah, it is in the center." It is in the center because it is located in the mid-uterine cavity. Understanding? It has a stalk coming from somewhere, from one of the lateral walls. The minute you put it inside, okay, uterus is a closed cavity. It is not going to be easy for you to find out where what has come from, right? So the minute you put this, you are going to understand.
Okay, so the dose of doxycycline and clindamycin, a lot of people are asking in the chat box.
100 mg OD. Clindamycin is, I think, 50 mg. I'm not very sure of the dose, but there is a Clindac vaginal pessary. So we give that Clindac vaginal. I think it is a 50 or 100. I'm not very sure of the Clindac pessary's dose, but we give that Clindac pessary along with doxycycline. Doxycycline 21 days, clindamycin 11 days.
Okay. So
along with probiotics.
Sorry. So the polyp which you mentioned, if at all, if it is not for fresh transfer or if there is enough time, so do you wait and see whether the polyp will resolve and then plan?
If I see the polyp, I will tell the patient I have seen the polyp.
Okay.
If the patient tells they want to wait for a particular cycle, all right, allow them to wait. See, if it is a polyp with a stalk, it is not going to go. If it is an endometrial aberration, that less than 5 millimeter polyps, they will get washed out with menstrual blood, correct? But anything which has a pedicle, remember, it has a vascularity. How will the menstruation take control of that vascularity which has developed an endothelium inside? It's not going to happen. So let them wait. 1 month, gaya, no problem. Come back. You see the polyp, patient is super happy. You had also told, other guy also told, Google also told, now remove.
So recurrent polyps, how do you manage?
Oh, that's a good thing. See, one of the things where recurrent polyps occurs is because your previous polyp has not been corrected correctly. Okay, see, the biggest problem is not recurrent polyp. You have done partial polypectomy in the previous attempt. Understanding? In order to do a complete polypectomy, if for a pedunculated polyp or a sessile polyp or whatever you call, you need to ensure that you go to the basal endometrium and you are flush to the basal endometrium. Understanding? Many times what happens is, especially for people who are using scissors, okay, listen, when you use hysteroscopy and when you use scissors, not everybody is as good as Sanket Pisat or somebody like that, you know, who are superb in hysteroscopy. So what happens is, for ordinary people like us, when we put scissors inside, sometimes, no, in that fast, that itch to cut the polyp is uncontrollable once that scissors go inside. Understanding? You will cut. And what will happen is, very small stalk will remain attached. Rest everything will come out. Okay, that small stalk will regrow in the next cycle. So recurrent polyp is due to partial polypectomy done. It is an iatrogenic thing. You need to ensure, okay, that it is completed.
So in your practice, the commonest finding in this hysteroscopy finding for infertility is chronic endometritis.
Chronic endometritis and Asherman.
Asherman, yeah.
And that is purely related to the crowd profile which I am treating. That is not related to a general practice. It is purely related to the crowd profile.
Yeah. So if there is a difficult embryo transfer, so do you post them for hysteroscopy the subsequent cycle? Is there any criteria?
We don't do that, madam. If it is a difficult embryo transfer, it is difficult, but the embryo transfer has occurred, right? So then if the patient is not pregnant, then I don't see a need to do a hysteroscopy unless there is some obvious cause. See, what is a difficult embryo transfer? You had difficulty in negotiating the cervical canal. You are not going to negotiate the endometrial cavity any which ways in an embryo transfer. Correct? Your hysteroscopy in a particular cycle has no guarantee of correcting the cervical disturbances in the previous cycle. It has got no such guarantee unless there is a cervical polyp, unless there is a cervical fibroid, something like that.
So do you do hysteroscopic occlusion of the ostia?
Hysteroscopic occlusion of ostia?
As in, like, for hydrosalpinx, do you do it through hysteroscopic route?
Madam, something more simpler is available. You must put a laparoscope. Okay, it is slightly above the umbilicus, 5 mm. Okay, and just take those tubes out. Why sit down and occlude from below?
Okay.
And you know, I have had 3 cases so far. So let me give an example. For people who love and promote hysteroscopic tubal occlusions. Okay. First, most of them are not done by the people who promote it. Okay. Second, when you put that occluder, okay, it is like a screw. That occluder is basically like a sterile screw. You will have countless examples that it is perforated on the other side of the tube. Okay. Because you are trying to occlude it through the narrowest part of the cornua. Okay. And it will perforate very beautifully. We have removed 2 occluders, okay, from the sigmoid mesentery like this. Okay, nothing happens. So that is why we don't want to do any such gimmicks. Better is to counsel the patient for laparoscopy. We don't even tell the patient air bubble test was there. Congratulations, your tubes are open. Rubbish. If the air bubble tube is there, it does not guarantee that the tube is open. It could be a perforated tube also. It could be intravasation, extravasation, which is happening from somewhere, which is causing that bubble to come out. It could be a bubble of your own hysteromat, inside whose pipe there is a bubble. Understanding where you are thinking that air bubble has come. Congratulations. No. You want to identify the tubes. You are Superman. Put a laparoscope. You want to cannulate the tubes. Very good. Put a laparoscope. You think that some problem is happening with the tubes which you have identified hysteroscopically, it's not possible. You need to go till the fimbrial end to identify if the tube is functional and patent. Okay. It's an important take-home point, I guess, because we see many reports of people who are so good, they will even identify esophageal stenosis through the internal os. How is that possible, madam? Tell me. How is it possible? Right?
Okay. So we see a membrane covering the ostia.
Yeah.
So to open it, does that signify anything?
See, it's very common, right? Flimsy endometrium covering the cornu. What the best thing when you want to move anything flimsy is go to that point, slightly below the point. Just increase your pressure of distension by 20 millimeters of mercury. Automatically, it will get dislodged. Trust me. You don't really have to put an operative sheath, operative instrument also. Just increase it by 20 millimeters. It will dislodge it. And you will be able to see it very nicely. Same thing happens for those level 1, level 2 irritating fibroids. Nahin? Figo type 2. Somebody has said Figo type 3. Somebody has said no kissing endometrium. Somebody said 1 millimeter from endometrium. In that, patient will eat your entire cranium. Why is it not coming? When will it come? When to push it inside? Shall I use ulipristal? Shall I not use ulipristal? 100 questions they will ask here for a surgery which you are not going to do. Simplest of the things in that, you put your hysteroscope inside, correct? Just reduce your distension pressure. If you reduce your distension pressure and if you see that there is something which is bulging through the cavity, that requires treatment. Okay. That particular fibroid requires treatment. Very simple. If it is not bulging through the cavity, again, very simple. It does not require any treatment.
Okay. So these fibroids that you remove, the myomectomy hysteroscopically that you do, always do you do it in a single sitting, double sitting? When is the time?
All single sitting. Everything is single sitting. I use normal saline bipolar resectoscope. I don't use glycine at all. There is no glycine available in my hospital, just like how there is no vasopressin. So I don't use that. I use bipolar resectoscopes. It is the standard of care. It is safe. And once you finish the learning curve, it is extremely easy to do it.
Okay. And for septal resection, so again, you don't use knife, you use the resectoscope, right? I mean,
it's individual choice. As I've told this many times, if somebody is comfortable using the scissors, use the scissors. Somebody is comfortable using the bipolar Collins knife, use it. As long as your septum is clear, nothing else matters.
so you do septal excision?
Sometimes. No. Septal resection most of the times. Okay. Septal excision only if it is a muscular septum. See, what typically happens is the more you go away from the internal os, the more the muscular that septum is. Right? It is still debatable. Every 3 years in a hysteroscopy conference, one time they will say excise it. After 3 years, they will say no, resect it. Just cut it. After 3 years, again some new paper will come. Again, they will say excise again. Only then conferences will happen. No, understand that thing. Okay. But for logical things, what is important is when the muscular component of the septum is more, you may consider to excise it. If it is just a fibrotic component, okay, you might as well incise it. But that is not true for hysteroscopic adhesions. In adhesion, what people normally do is a cut in the center. Khatam. No, it's an adhesion because there is some fibrosis on the anterior wall and posterior wall. So you must actually do excision, like how we did it in Bangalore. Remember that girl who started getting menses? We excised that entire adhesion. So when you excise that adhesion, the patient usually responds well.
Yeah. Yeah, that's about it, I think. So do you do without anesthesia all the
office procedures? Yes, office procedures without anesthesia.
And then if there is any operative like multiple fibroids that you removed hysteroscopically last week, so that one.
Yeah, that is under GA. No, proper GA. Hysteroscopic. See, I will almost always do every procedures which require operative work under anesthesia. Okay, I like to do it that way.
Okay. Yeah, I think that's about it. We'll take the rest of the questions in the groups, if you don't mind.
No problem.